So let's start with the niyat that inshallah, whatever we are going to talk about is going to eventually benefit our patients, and that's why I think we are here. So briefly, my name is Dr. Hassan Salim. I'm consultant cardiovascular and cross-sectional imaging radiologist, working as a technical lead at IDC. So I'm just going to go through quickly through just the brief introduction. We started doing cardiac MR in 2016 in collaboration with one of my best friends. He's a cardiologist from Virginia. I was formerly trained in cardiac MR and currently working there in Arizona. So we started doing in 2016, started doing it at Rawalpindi, and now slowly spreading, and it's still in the transit phase. So I started using G Cigna initially, and then now we have Ingenia, and now the new 3 Prodiva Ingenia in G8, Rawalpindi, and Ahmedabad. I use Cardiac VX for my G images. New SP is really fascinating in that way that it's a single-click functional assessment. In my opinion, it's a teamwork. So what you need is really good machines, obviously, but you can't really work without good team of cardiologists and radiologists. You need to have a very trained staff, technologists, and especially you need to have a very good nursing staff if you are doing your stress imaging. Study duration usually is long. People are working on ultra-short protocols now. Usually, and mostly obviously, the breath hold sequences with ECG gating. You need to, like I said, you need to have trained staff, MRI machines. And if you're doing stress imaging, you need to have MR compatible infusion pumps. Protocols are very, interconnected, multiple step imaging protocol. So if you get interrupted right in the middle, so you have to restart the imaging right from the step 1. That's a big challenge. So usually we do this workshop for like about an hour or so, but time is brief and our moderator is strict, so I'll just keep it very brief, quickly go through the indications, and then we'll go to the case discussion. So introduction, obviously CMR, been there 1980s, non-invasive imaging. That's a consensus document, basically published in 2010, mentored by Dr. Hundley. He's also a mentor of Dr. Suleiman. Then European Society of Cardiology has designed their own guidelines. Advantages, as you all know, difficult patients, which are still our patients, no radiation, no iodinated contrast. Then you can acquire various planes. No artifacts there. Then you can assess multiple different parameters. The best thing about CMR, it has high reproducibility and low variance. These are multiple limitations as well. Obviously, if you're dealing with claustrophobic patients, patient with the poor cardiorespiratory reserves, it has longer exam time. Cost is another issue. Then incompatible devices is a limitation. And then obviously you need to have good eGFR, at least more than 30. So some of the basic indications, obviously the first one is coronary artery disease. You can assess for the ischemia, the functional and the mass assessment. Then we have one of the major indications is viability for the thickness. And obviously it's superior to thallium SPECT and comparable to FDG PET. It's one of the most documented and most shared document which showed the importance of CMR in the past. It was published in 2003. So they concluded that for the large infarcts, transmural type infarcts, the SPECT is comparable to CMR, and to the histological correlation is there. But when we are dealing with small subendocardial infarcts, CMR has a big advantage there as compared to the poor sensitivity of the SPECT. And obviously all indications of non-ischemic cardiomyopathies, it's very good in HCM, DCM. It's like a gold standard in ARVC, since it's very difficult to image sometimes the right side on echocardiograms. Then all kind of restrictive cardiomyopathy, sarcoid, amyloid. So it's like an ant mini on cardiac MRI. We do see a lot of myocarditis. Cardiac masses is absolutely great. Then amazing in constrictive pericarditis. It's really easy. We do some valvular diseases, congenital diseases, Again, very good and very robust for the assessment of thrombus versus mass. And we do have lots of patients with thalassemia in Pakistan, obviously. So I do get a lot of patients with iron overload, then for arrhythmia risk stratification and the disease of the aorta and great vessels. So I'll just skip the entire technique part. So I'll just share the case library. So that's the first case. And this is basically a normal cardiac MRI. I just want you to visualize and imagine that you're actually looking at the real-time images comparing it with the echocardiograms. So this is a two-chamber view, and we can acquire short axis. Then this is a three-chamber view in which you can see inflow, then left ventricle, and that's the outflow tract. And this is the LVOT. That's like a coronal view in which you can directly visualize the aortic valve. This is the four-chamber view, and you can see the nice contractility of the heart. It's very good. You can always look at the flow of the blood from the atria into the ventricles, and obviously it can give you so much information. And like I said, it is reproducible and it has very low variance. And you can get incidental findings like it has a hepatic cyst. Then we do the short axis stack. You basically move from the apex towards the base, cutting it like a bread piece. And here's another case. You can see biventricular, biatrial enlargement, and the heart is very slow in that regard. Now the next case is one of the common indications, the viability studies. So here's a case where you can see relatively thinned out interior and markedly thinned out akinetic apex there. So on cardiac MR, it's fairly easy to evaluate the thickness of the infarcted tissue. So like I said, the black part is the normal myocardium, whereas the white part is the abnormal myocardium, which is the infarcted myocardium. So what happens is that the contrast is pooled in the infarcted tissue, and you can't really see the washout on the subsequent images. So all you can do is just take simple thicknesses at variable levels. Obviously, if it's less than 50%, it's viable. If more than 70% is gone, then that's non-viable, more in the transmural. Somewhere between 50 to 75%, it's a gray area, so you can always think about stress imaging. Next is stress perfusion. Again, it's very easy, very robust to perform. You can give the adenosine. We usually use adenosine in our perfusion studies. We inject adenosine at the rate of 140 mics per kg per minute. You can increase or decrease it according to the patient's condition. And then you inject the contrast in the last 1 minute. Basically, you're infusing it for like 3 minutes. And the last 1 minute, you inject the gadolinium, so you need 2 bore cannulas on each side of the arm. And that's the stress where you take one at the almost at the apex level, then at the mid level, and then at the base level. So you can see the perfusion defect mostly in the subendocardial places. Obviously, you need to correlate it with the rest imaging if required and with the late gadolinium images. So pericardial effusion is very straightforward diagnosis, not a big issue there. That's a case of nephrotic syndrome with massive, it had a moderate pericardial effusion and pleural effusion as well. That's a case of mitral stenosis. Here you can see a very tight mitral valve there, and you can see how the left atrium is all ballooned up. So again, you can look for the regurgitant fraction, you can do the planimetry, and you can assess the functional assessment of the rest of the chambers. This is the case, again, the aortic stenosis. You can see how the blood is going to and fro pattern. It's striking against the aorta, and the aorta is also dilated there. You can do, again, that's the plane rightly going through the aortic valve. It's functionally bicuspid, and it's severely stenosed. You can see the measurements, and you can always do the phase contrast study for the flow assessment. Very good in cardiac masses. This is, I think, one of my first cases that we did in 2016, presented to us with some kind of mass in the left ventricle, initially on echocardiogram thought to be some kind of a mass related to perhaps the valves, I guess. But here you can see a mass there, infralateral wall. It was enhancing on the LG images. So Salman called me up and he said that, listen, this looks like a secondary coming from somewhere else. So you need to look at other images. So when we checked the axial fiesta images for the anatomy, we found out she had a big lumps there, big lymph nodal masses in the left axilla. So we kind of convinced her that she needs to go through the excisional biopsy. And this is the result. And this turned out to be a Hodgkin lymphoma. And these are the patients who actually benefit from cardiac MR, because now, alhamdulillah, she's alive. And I've followed this patient for so long, and her mass within the heart has calcified after the treatment. That's a case of tuberous sclerosis with rhabdomyoma. Again, you can see a mass there. Then that's an unfortunate case. He was born in 1986. Someone in 30s, young guy. I think it was in 2018. And this patient was referred to us with the echocardiogram stating that the patient has a fixed anterior wall. There's a mass-like area going into the left ventricle. It could be a thrombus, could be a mass. So what we found out was engulfing, fungating mass there, almost eating the entire LV. And additionally, there was another metastatic deposit in the right atrium. These are the LG images, heterogeneously enhancing mass, fungating, engulfing the left ventricle. I don't have the histopathological diagnosis of this patient. Unfortunately, this patient died on the OT table during the biopsy. Another young guy in our ECL Lahore branch with thrombus, saddling thrombus there near the bifurcation of the aorta. And on the echocardiogram, they found out a mass-like area in the left ventricle, wanted to rule out thrombus versus mass. So we perform early gadolinium images on high TI values of 600 or maybe more. And you can see the myocardium is enhancing in early gadolinium images, whereas the thrombus is non-enhancing. And similarly, on the LG images, we found out multiple subendocardial small areas of infarcts, probably due to thromboembolic phenomena. Another case with the LV apical big infarct there, and you can see a fluttering thrombus there. It was about to go into the aorta and disseminate into the systemic circulation. Another case of mine, it presented to us in 2022 after a valve replacement done 10 years back, developed a thrombus there. You can see a small triangular thrombus there at the apex. And there was no LGE. And in 2023, in fact, 2 weeks back, this patient came to us with frank stroke. And there's the thromboembolic phenomena likely from the cardiac cause. And the MCA is gone and the vertebral is gone. This is massive kind of embolism leading to brain infarct. Another case, HCM, obviously it's another discussion, a long discussion there. But in short, it is very good for the assessment of HCM as compared to echocardiogram. You can assess the LVOT. You can see the SAM there, and you can see what various factors are there which are causing HCM. And the obstruction there. So on black blood images, we usually see very thick front-like pericardium in different distribution. Then we always see some kind of enhancement in these big muscles, usually at the RV attachment site. Then there are other variations. Like I said, it's a huge topic, but just to show you, this is a mid-ventricular variant. Here you can see slightly aneurysmal apex there, and a small clot is sitting there as well. So again, like you said, it's not enhancing, and there's an infarct there. It's more of a ischemia due to turbulence flow in the apical region, leading to fibrosis. So we'll just go through asymmetric HCM. That's another variety. Anderson-Fabry disease. We need to run TI mapping. Next case is of the constrictive pericarditis, another long discussion. You see a long, thick front of pericardium around it. That's a black blood image. You see the enhancement of the pericardium there. And again, it's very easy if you follow the grid and the stripes there. Basically, these are placed to see. No, it's getting stuck now. So we'll just switch. So the grid, if it breaks, that means the contractility is normal. If it's not, then that means this.
So while your slides are coming up, those are some excellent cases and images. What scanner do you use?
I use G Signa Explorer initially. Now I'm using Ingenia in 5 settings. 2 Ingenias and 2 Prodiva Ingenias. So we'll switch the constrictive part. This is the septal bounce that's easily appreciable in the constrictive cases. This was the case of sarcoid presented to us with some kind of VT, was known case of sarcoid. We followed this patient up, again, large nodes there with calcification, and ICD was placed. Next case is COVID myocarditis, very unfortunate patient, young guy, traveled all the way from Karachi to Islamabad, which is very unfortunate in this country. Here you can see massive enhancement there. The entire heart was gone almost, 15, I think 20% ejection fraction, young guy. Non-compaction is a straightforward diagnosis. Amyloid is another discussion. Again, you see biventricular bioatrial enlargement. There is no myocardial nulling. That's another separate topic. But here you can see the myocardium is not nulling at all, and there is no nulling on the T1 cine images, look-locker sequences. Here you can see florid enhancement everywhere, and TI values are usually high, so that's a very simple, straightforward case on cardiac MR. ARVC, again, which is like kind of a problem on the echocardiogram, but on again, on cardiac MR, it's pretty easy. You see hardly moving right ventricle. It's dyskinetic, poor ejection fraction, and EDV index is usually raised. Sometimes you see fatty infiltration there, but that's not part of the criteria anymore. And you can see that there is an enhancement in the right ventricle as well as in the left ventricle. Last 2 cases, this patient presented to us thinking that probably it's ARVC, but turned out this is ASD, and sometimes there's an overlap between the features. Last case, one of my favorite topics, these are iron quantification in thalassemia patients. That's very easy. Again, why you don't do biopsies? Because it is all kind of random distribution. It's a nodular infiltration of the heart. If somebody biopsy this patient from here, is going to turn out to be mild inflammation. So that's why we prefer doing cardiac MR in these patients. These are various reference ranges. And that's the last thing. These patients, like this patient, had 5 millisecond T2 star. Liver is also has significant iron load, and now the ejection fraction has gone down to 40%. This is the case that I followed up and then improved after the chelation therapy. I thank you all.